project. So the Thrive project is comprised of Afrocab, where I serve. It's a regional community organization. We also work in collaboration with Clinton Health Access Initiative, CHAI, as well as Penta. And the Thrive stands for, I'm sure there's a banner somewhere that says Thrive. So it stands for Transforming Advanced HIV Disease Care in Low and Medium Income Countries. All right, okay. And we do this through comprehensive and equitable access. So the Thrive project is reducing HIV mortality in adults and especially in children, because we know that children are a vulnerable population. And we are enabling access to critical prevention, screening, as well as treatment services and commodities. So as the community engagement partner, Afrocab is leading efforts to maximize the involvement of affected communities from conceptualization to implementation, as well as sustainability. And the Thrive project is demonstrating what it looks like when communities are involved in driving the response. So through the Thrive project, we are accelerating access to new technologies. We are simplifying linkages between communities and the facilities. We are identifying and re-engaging clients who have fallen out of care. We are strengthening community systems as well as decentralizing care. So we are very passionate about the work we do, and this is because we are a community organization. But we also know that despite all the advances in ART coverage, the HIV mortality is still very high, and we cannot continue to lose more than 6,000 people every year to HIV. And so we need to do something about this. So I hope that by the end of this session, each one of you becomes an AHD champion, an advanced HIV disease champion. And I hope that you can pick a fight with AHD and become a champion. So allow me to thank United, our funder. Allow me to thank our partners, CHAI and Penta, who we work with on the consortium, the Fight AIDS Coalition and the GNP Plus, as well as the networks of people living in HIV in the 5 countries where we work, which are South Africa, Zimbabwe, Kenya, Nigeria, and Uganda. And I thank our CBOs, the CBOs that we work with in the communities, in the facilities, as well as the other implementing partners. Most importantly, allow us to thank the governments that we closely work with in these facilities and at national level. And we are now truly partners and we are meaningfully engaged. So thank you very much for coming to this satellite. And this session today is in 2 parts, as you can see from the schedule, and it's dubbed Turning the Tide on Mortality Through Early Community AHD Case Finding. So we'll have, in the first part of the session, we'll have presentations from Sisi. Sisi is the program manager for the Thrive project on the Afrocab side of things. And she will be talking about community-led pediatric AHD case finding interventions and reduce mortality in 5 countries. That's Sisi, a big hand for her. The next presenter that is after Sisi is Lebo. Lebo works at one of the facilities in South Africa called Levi Mbata, and she's an AHD champion. So she's going to discuss her work, the interventions she's involved in, and what she does to ensure that the AHD cases in the communities are found early and referred quickly to the facilities. So the second part of this session will be a panel discussion, and we'll have representation from United, from the governments, from CHAI, as well as we'll have Afrocab staff come to discuss about our topic today, and this will come after the presentation. So thank you very much once more, and I'll call upon the first speaker, who is Sisi, to take us through what these interventions that are allowing us to find these cases are. Thank you.
Thank you so much, Tamara, for introducing Afrocab. I'm going to be sharing our experiences in identifying AHD among pediatrics and the adolescents. And this work is being done in 5 countries, and it is complementary to our AHD champions and facilitators who are one of our frontline workers, as well as a multidisciplinary team. So our presentation is going to look at a community-led approach to pediatrics, as well as the last mile as one of our intervention model. And we are going to share the retention and also identification and call for action. Tamara has already explained what Thrive is, and I won't go into details with it. So we use facility and community interventions in our work when we are identifying AHD among adults and children, but this presentation is going to look more on the pediatric and adolescent side. And we have managed to use those interventions within the community and the facility, which has yielded results in early detection of cases for AHD, ART retention, and also this has enabled us to improve quality of and lives of people living with HIV. And in July, we managed to identify 62 cases, which increased in October to 106 AHD among children. Our retention also improved from July from 364 to 740 in October 2025. When we look at last mile, this is exclusively implemented in Nigeria in one of the Benue states, and it improves AHD case findings for children living with HIV and also making referrals and follow-ups. During the September month, we managed to identify and confirm 20 AHD cases among children, and we also strengthened the linkages of 13 EMTCT mothers. We managed to provide different integrated services, which are listed there among the caregivers, and also nutrition support, as well as improving retention, where we managed 220 recipients of care being engaged into care between July to September 2025. There is a photo there where we are conducting the last mile outreach in Benue State, and this was in an IDP camp where we have those people who have been confined in such places. We do demand generation, and this supercharges case findings. We have ambassadors, and we have a picture of one of our ambassadors, Dr. Watiti. These use their lived experience to generate demand for AHD services within the community, not only for children, but also for adults. We do capacitate communities, and we have been able to provide small grants to our network of people living with HIV in the 5 countries. We have worked with the Ministry of Health, the networks, as well as other partners to co-create IEC materials which are looking at AHD so that this can be used in our communities. And we managed to reach more than 140 people with different services, health talks, awareness campaigns, and outreaches between July and October. And that is a sample of one of the materials we co-created. When it comes to identification, between July and October, we had 806 cases identified, and these were sent for screening. And out of these, 283 were confirmed with AHD, which yield 35%. As we said that we work in hard to reach areas, you can see one of our champion at the facility receiving a 2-month baby from one of the islands in Uganda, Busi Islands, and this was tested and tested HIV positive as well as was confirmed with the TB. With the retention, we have managed to retain, as you can see there, from 0 to 5, it was 90%, from 6 to 14, it is 88, as well as 15 to 24, it is 84%. And this opens our eyes that this adolescents need support when it comes to retention. In the photo, a facilitator had conducted a home visit in one of the villages where one of the recipients of care had interrupted treatment for 5 weeks, and they had to do counseling, and it was referred and it was confirmed with the AHD, and which was TB. As I conclude, I would like to call to action all partners, frontline health workers, the community structures, and also caregivers, and all of you who are here today, so that we strengthen and enhance community and facility linkage, which can help us to initiate Stop AIDS package and ensure that no child is left behind, because we need to support our children who are living with HIV. I would like to acknowledge United, our funders, who have enabled us to do this work in the 5 countries, and also our champions and facilitators who go into the community, like the previous speaker said. Communities are taking lead, and this is what Afrocab is doing. We are empowering communities to take lead and make sure that they support each other within our communities. The Ministry of Health in all countries where we are working with, the community stakeholders and the national network of people living with HIV, we thank you so much for supporting this work. Thank you all for listening.
Good day, everyone. As introduced, my name is Lebu from South Africa, in Levimbata Clinic in the historic place called Everton. Mine is just to say, when we are not putting strength on community-led AHD screening, it means we want to win against high mortality rate on AHD. It is important as we are able to reach the hard to reach populations and high risk groups such as PLHIV, youth and adolescents. Our objective on AHD community screening is to reduce stigma. As we know, we still have a high rate of stigma in other places regarding AHD and HIV in particular. We are able to facilitate, oh, sorry. We are also able to facilitate early screening on diagnosis and treatment, and also reduce AHD mortality.
The Thrive community interventions, um, we mostly go to those hard to reach communities. We are able to target the PLHIV sectors that are undiagnosed, at naive, and suboptimal to adherence and to enhance AHD findings. Late presentation of HIV care leading to high mortality. As community-led AHD screening is crucial for the hard-to-reach populations, we normally go to the high-risk groups such as TB contacts, adolescents, and youth. The methods that we use to reach those hard-to-reach places, we do door-to-doors, home visits when tracing, missed appointments, and we do outreaches and campaigns. We also do support groups meetings. Post-discharge care. It is important to those patients that were hospitalized, as we emphasizing on same care as the inpatients, because they are mostly being ignored when they get home. We also help with continued management of OIs, and our objective is to ensure timely identification of complications, adherence to health facility discharge plan, and our goal is to improve health outcomes and mobility and mortality. Um, the components, it's person-centered post-discharge care plan packages that allows the care and support services patient will need after leaving the health facility. As AHD champions within communities, we make sure that we put effort in supporting and caring for outpatients even after they get out of hospital. Um, Why community-led case findings? We detect and access to care early, trust and reduce stigma. We know communities are still stigmatizing against HIV and AIDS, especially AHD. Now, if they see AHD champions within communities doing their job, ours is simple because some of us are PLHIV, ourselves as champions, now interacting with communities when it comes to AHD related illnesses, it becomes simple because they see as the person that you are doing the job, you yourself is also part of what they are going through. Now it becomes so easy for us to interact with communities, and they are able to trust us. We are reaching the underserved populations in the communities, and they are very welcoming when they seeing us. And we empower and empowerment and ownership sustainability. We need to do things that are able to sustain information within communities when it comes to AHD. So we're not supposed to be just doing the once-off programs, but we need to do continuous and sustainable trainings and also information sharing sessions. The reduced AHD community mortalities. That is what everyone here wants. And as champions, AHD champions, we are able to do that moving forward. And even now we are doing that. Our recommendations is to improve access to commodities, collaborate with community stakeholders, which by right now, stakeholders are very happy to work with the Afrocab AHD champions. Capacitated communities for sustainability. We need informed community members. We need informed patients so that they know better how to take care of themselves. Um, I would love to acknowledge Unitas for preparing all this and for trusting us as AHD champions and facilitators to do the job that we are doing in the 5 countries. Also the Clinton Health Access Initiative, the Penta. We are very grateful. Moving forward, we promise that we're going to do more. Thank you.
Thank you so much, Sisi and Lewo, for sharing what's happening on the ground and all the interventions that we've put in place. So we have a Q&A session after the panel discussion, and in the interest of time, I'll be handing over to Jackie Waboy, who's our CAB Community Advisory Board coordinator, to introduce the panel and move forward with the program. Thank you. Please, a big hand for Lewo and Sisi.
Yes, good morning, everyone. In case you're wondering what advanced HIV disease is, as you've heard, my name is Jackie Waboy. I work for Afrocab as the regional CAB coordinator. So the World Health Organization defines advanced HIV disease as having a CD4 count of less than 200. It's even two. Okay, I like this. Okay. Yes, as I was saying, AHD is actually a person living with HIV presenting with having a CD4 of less than 200 or having WHO stage 3 or 4 disease, right? And for all children who are under 5, who are not clinically stable and not receiving ART and is diagnosed as having AHD regardless of the cell count. So moving forward, I'm going to ask my panelists to please come up to the stage. And I will start with Bahati Haule. Please join us up in front. Bahati Haule is our Pediatrics and Adolescents Officer at Afrocab. I'd also like to ask Dr. Karen Atieno from the Ministry of Health in Kenya. Dr. Karen is the Advanced HIV Disease Focal Person in Naivasha Sub-County Hospital, which is actually the best AHD Center of Excellence in Kenya. And lastly, I'd like to introduce Carmen Perez from Unitaid. Thank you. All right. So I have a few questions for you, my panelists. Are you ready? Ready? Great. So I'll start with Bahati. So based on feedback of the recipients of care, what are some of the most critical change that us as communities have made to HD programs that have directly improved service continuity and reduced loss to follow-up? Over to you.
Thank you so much, Jackie. So with the feedback that we receive from our communities and recipient of cares in the 5 countries where we are working, so one of the greatest feedback on the work that we have done, which has supported retention, but also that has supported retention and continuity into care, has been complementing the work that the government and facility has already been doing. So not establishing any new system that people have to understand and get used to, but complementing system and communities of people that were already existing within the area, but also acting in decentralizing the services that we provide. So we work with communities and the case manager and the facility team in order to reach people who have fallen off to care, those who are yet to be identified, and those who are yet to be suppressed or better adherence into their system. So this works because a lot of time the challenges that people face with living with HIV until they become into the stage of advanced HIV disease all surrounds the issues, whether it's stigma, whether it's logistical challenges into going into facilities or it's lack of information. So we work closely with communities to find them where they are, give them the information and support we need. And we have decentralized services into models that are friendly to people in order to support their retention and adherence into services. So working close into existing system, working with facilities, with governments, but reaching people where they are and giving them strategies and services that cater to their needs at their communities. Thank you.
Thank you, Bahati. And I'm requesting if IT can reduce that echo, please, so that we can be able to hear the responses from the panelists. Thank you in advance. Dr. Karen, the next question is for you. So what steps does the Ministry of Health take to dismantle policy or procedural barriers that hinder seamless community to referrals for children with ADHD? And what are some of these barriers? Over to you.
Thank you very much. Thank you, all our listeners and all our partners that have given us the opportunity to be here. For our Ministry of Health and the governments to be able to reduce the barriers that hinder the access of children with ADHD getting care and getting it promptly, one of the things that we have done back in Kenya is ensuring that there is a standardized advanced HIV disease package of care. And this package of care cuts across the whole country. It's being rolled into all our 42 counties, and to ensure that the care cuts across. There's also involvement of the community ADHD champions. And as one of the speakers earlier had alluded, that these are actually the people who are in the community, rooted to the nitty-gritties of understanding of what goes on in those communities, and they are able to identify very closely with these patients. So ensuring that they are part and parcel of that care cascade is one of the areas that the government has taken care of. Digitization, all of us are living in the space of digital era. So strengthening the electronic community health information system is one of the parameters that we are taking to ensure that we are able to track these ADHD children across board, and also ensuring that the policies that are developed around the community and facility linkages well defines the roles of each member, especially of the community health practitioners. These barriers are actually around the same discussion. So we have barriers with protocols and bureaucracies of referral. So to break through that is to ensure that if a community health practitioner or community health worker refers a child into a facility where we use the hub and spoke model. So the spoke is the facility nearby and the hub is the referral facility that have all the capacity to manage ADHD at all levels. Those children do not queue up again, but they are prioritized to receive care. And that is one of the way we can be able to break the barrier. Documentation is very key for us to ensure that the referrals from the community and into the facility are well aligned and the person receiving them are able to follow up in the care. And then finally, involvement of partners. We know that partnership is inevitable in the care for advanced HIV disease in terms of commodity, human resource, as well as the tools that we need to be able to take care of these. And I would appreciate all those partners who've given us the opportunity, starting with UNITAID, Afrocab, the Ministry of Health, and all of you here, because all of us are champions. Thank you.
Thank you so much, Dr. Karen. Hi, Carmen.
Hi. Good morning.
Yes, this one is for you. So why is direct community engagement and not just as beneficiaries, but actually as co-creators, now considered a non-negotiable component for the success and sustainability of HD interventions? Over to you.
Thank you. I hope the echo is okay, but this is a very important message, so it doesn't mind if you hear it twice. So, all the message from communities and advanced disease. We all want to reduce mortality, we know, and actually it's a very stubborn statistics that we still see today, despite, can I go there because I think it's less echo.
Maybe, yeah.
Sorry, I know. Oh, that's better, isn't it? Yeah, great. So I was just saying anyway that the echo will not be an issue if we need to hear this message very much, because communities are indeed very needed as the pillar that can help, together with all the national stakeholders, that is clear, on resolving these stubborn statistics that we have in terms of advanced HIV disease. It is a multi-dimension problem, we all know. It's not easy. There is many things related to access to tools, to overburden health systems. But what we know is that the root causes for this situation will actually will not be alleviated without your work in communities. And they need to be involved from co-creation. That's the question. And I think it's very important to understand that. Many years we have given communities' involvement for granted. They were nice to have, but actually not having sufficient resources, their contributions will not be meaningful. So at UNITAID, we believe it's crucial to incorporate communities as well on the design, together with the national program and the national stakeholders, to be part of the design of the solution. Not passive stakes, but actually being active. For example, in the projects, we have community advisory boards that actually help on designing the projects, but also on the monitoring of the implementation, so that when they detect gaps in the last mile, the information can come up to, as well, the national program and all the other actors, and together think on a better solution for the service delivery that reaches the most vulnerable in the last mile. We saw some examples of how this works. And actually, it also raises the capacity of these communities to be informed, to be part of the technical working groups, to be on the national discussions, and for us, that is really key. For that to happen, we need capacity building. You mentioned the speakers before, the brilliant speakers mentioned the treatment literacy. We do need to have more information. The access to technologies is very complex, and we need to ensure people are aware of which tools are the best for the opportunistic infections that eventually will kill people living with HIV. So very importantly, again, communities are part of the solution and has to be part of the design. And I know that all the national stakeholders second this, and we will be continue to work all together to find a solution, as well as ensuring that we can have continuation on treatment for children as well as adults, to avoid advanced disease in the future having such bad statistics. Thank you very much. And thank you, Afrocab, for inviting.
Thank you so much, Carmen, and also thanks again to our panelists. So now we are giving opportunities for any questions that you may have, and I will request our presenters to come up just in case there are questions for them, Lebo and Sisi. Do we have any questions from the audience? I see a hand there. I'm not sure how this works. There's a hand there. Where? Where is the mic? There's a hand on the mic. Side.
Okay, yeah, the mic is here.
Okay.
Yeah, good morning, everyone. My name is Barbara Kemigisa from Uganda, and I would love to thank the presenters. First of all, to look at, I'm sorry, my site isn't so good, but what's happening at the community, I would love to add to that. Unfortunately, a lot of funding has been going to the big organizations and community-based organizations that are going deep to the communities, and the PLHN networks have been given very little money, that even doing what we are supposed to do at the community levels becomes very, very difficult. So we are saying, let's strengthen our community intervention. And like the last presenter has said, it is taken for granted. I want to share from the experience of what is happening in, okay, let me wrap it up. I want to share an experience of what is happening in our community. You can't hear me?
We only have time for question and answer, my dear. So your question is about funding for communities, right? I'm going to ask Sisi to respond to that. Thank you.
Okay, I really want to say this is an opportunity for us to speak, to share what is happening in our communities. We are people living with HIV who are meant to be going deep with the people we are serving, like us, who are not being able to be represented here. The truth is, we are being taken for granted. I'm standing here frustrated because the government wants to give me a bill of 50 million because they don't believe, as a person living with HIV, I can volunteer to serve my community. So if she is saying we are being taken for granted, it is true we are being taken for granted. We are not going to end advanced HIV disease. We are not going to see zero transmission of mother-child babies because people are frustrated in the communities. We cannot see medication happening. There is no mental health for mothers. So mothers are literally not taking medicine. Their husbands are drunkards who are not even giving time or money or any support to these mothers. Recently, our children are becoming positive because there is no support at all. And these are things we are not supposed to talk about here because there is no time. It's really not fair. There is so much I can explain, but if there are spaces that we can be given this opportunity.
Okay, thank you so much for that contribution. As Afrocab, we are community organization, and we have so far had to grant small grants to organizations or community-based to work within the communities. It's not that we are working with a big organization, but we are going to the community because we are a community-based. So within the countries we are working in, the 5 countries, Kenya, Uganda, Nigeria, South Africa, and Zimbabwe, we are working with the community-based organizations. That's where you see that we have champions and facilitators, and these are people living with HIV who are supporting community work at grassroots level. That is what I can really say to you. I'm glad that you are from Uganda, a country where I'm based, and we can touch bases and see what we can do together to end AHD among people living with HIV. Thank you.
I saw another hand on that side. I'm not sure how the mic is going to get there. Yeah.
Sorry for the hassle. I'm Kenyan, so the Kenyan should not respond to my question. We can discuss that when we go back to Nairobi. But for the non-Kenyans in that panel, I'm not sure whether they're hearing. The question is around funding. Do you see this as something that your government can fund? Because United is starting us off, Jai is supporting us, but the future of this is for country government to fund it. Do you think country government can fund, including my sister from Uganda who is frustrated? Can their government fund what they are looking for?
Okay, thank you. I'm not going to respond, but I'll just repeat your question because we couldn't hear you. I'm also from Kenya. So the question is on sustainability, and the question is, do you think the government can fund AHD programs?
Thank you so much for the question. I'm going to answer from the Tanzanian experience, where I think the great work that is part of the parcel of Thrive that we are doing is also ensuring advocacy with our government and system in countries. So as community advocates and civil society, speaking from the Tanzanian experience, we have been working in pushing domestic resource mobilization, but also social contracting, where we have created guidelines and frameworks in place where it comes from the priorities of the communities. So how do we influence the area where the government can support community work? So it really relies on us communities and networks and advocates and activists in our countries to push and demand for our government to prioritize advanced HIV disease. So we understand everything is a priority, but if we come together and rally on what's important, so in our national health budget, whether it's in our global fund cycles, whether it's in our domestic resource mobilization and efforts by the AIDS Commission or Ministry of Health and Ministry of Finance, is how do we stay in those spaces, whether it's the technical working group, the subcommittees, whether it's the conferences and workshop where we go and push the decision makers and those in powers to prioritize, whether it's commodities, whether it's awareness programs, whether it's supply chains and community healthcare workers in the HIV and advanced HIV disease space. So it's happening in countries. It's different from one country to another. That's why I said I'll answer in the Tanzanian experience, where we are prioritizing advanced HIV disease in our health budget, in our domestic resource mobilization, but also social contracting framework between governments and civil society. Thank you.
I think I had seen a hand here.
Thank you. Thank you very much. I'm Sule Sunday from Nigeria. My question goes to the second to the last panelist, where she spoke about the use of EMRs in the finding of AHD cases. So I want to ask, what other technological solutions have you implemented or do you think can be implemented in accelerating the finding of AHD cases? Thank you.
That was for Dr. Karen, right? Yes. Yeah. Did you hear the question? So he said you mentioned about EMR in tracing AHD clients, and what other digital platforms do you use?
Thank you very much. I hope I got your question clear. Like, what are the digital platform are we using to be able to get hold of AHD patients? So in Kenya, we are rolling at a low level scale, a tracker, an AHD tracker that is in testing platform at the moment in the centers of excellence. And this is a real-time platform that is able to identify the AHD clients in the different centers of excellence. We have 6 at the moment in Kenya. And so these trackers are being held at the Ministry of Health. That is where we are hoping that they will be hosted. But the different facilities are able to see in real time the inputs that are coming from the different facilities, the patients that we are having or the clients at that moment. So it's not rolled up in the whole country, but it's the testing platform so that we are able to roll it out to the entire country with the aim of ensuring that we do not get lost to follow-up of patient along the way from the community into the spokes and into the hubs. So that tracker is going to be a game changer for us, depending on the user acceptability. So we are trying to make it as simple and user-friendly as possible. So it's being modified here and there depending on the experience of the users. I hope I have answered your question. Thank you.
I see another hand here, and I think there was. I'll come to you. Sorry. Yeah.
Okay. Dr. Ibilibo from Nigeria. Thank you very much, presenters. I agree that funding is very important in the discussion we are having. The community is very important. From the experience of the presenters and the discussant, I just want to know the community-based organizations from the countries you work. Is there any initiative that you have, or what are they doing